please welcome me in joining Dr. Sen.
Hey guys, thank you. Can you guys hear me okay?
We can.
Okay, good. Thank you so much. I'm so sorry. For some reason, I thought the presentation was at a different time. And so happy to have this opportunity and thank you again. The topic of PDA is a little bit very vast. And when we talk about all the different potential areas of where we can talk about the PDA, I thought it might be actually a little bit interesting to talk a little bit about the role of PDA in acquired and congenital heart disease, as well as some of the management strategies that we would be thinking about. And so I'll talk a little bit about the outline here, but I have no disclosures. Um, so I was hoping that for this talk we could understand really the heterogeneity of how the ductus can play in so many different roles, not just in acquired congenital heart disease or acquired heart disease, but also in congenital heart disease, as well as to really start to think about what would that phenotype look like when we see about when we term ductal dependency. And then we'll dive a little bit into what are some of the considerations for ductal patency and that management. And then at the end, we'll finish up with talk a little bit about preterm population and the ductus, as well as review some of the medical and surgical managements that we do in our hemodynamically significant PDAs. So I do want to try to keep this interactive, so feel free to use the chat box. For some reason, there we go. Okay. Yeah. So if anything, please do use the chat box or raise your hand, and we can keep this interactive. So, the ductus arteriosus, it is a intersegmental artery. If we remember back in our embryology days, and we look at the aortic arches, it's between the fifth and sixth aortic arch, and it connects the aortic isthmus to typically the left pulmonary artery. And what I do want to point out, and we'll talk a little bit about this later, is that there is a intersegmental artery on the right side that tends to go. But TBD, we'll talk a little bit about that when we do have persistence of that right intersegmental artery. This was first described by Galen almost 200 at 200 AD. Almost, how so interesting to see how even in the Roman time period that anatomists like Galen were first able to mention that there was this vessel that was found, but at the time didn't really know what to do with it, nor was it physiologically relevant at that time. And it wasn't really until the advent of prostaglandin that we really started to know what the function of the ductus arteriosus was like. So, just a quick recap from a fetal perspective, we know that about 40 to 50% of blood gets shunted from the umbilical veins through the PFO and contributes to your LV contractile volume. The ductus, primarily in the fetus life, shunts 80 to 90% of the blood that gets down to the RV into the pulmonary artery, if you guys can see my mouse, and shunts about 80 to 90% of that residual volume through the duct to contribute to the rest of the systemic output. And, again, when we think about the postnatal circulation here, it really is a volume load to the lungs and the left side of the heart. And so when we see blood shunting out the aorta, your systemic vascular resistance is much higher postnatally, and we see that left to right shunting typically as that PVR is lower, which leads to an increase in your lung volumes as well as the left side of the heart in terms of that volume load. So as a quick recap of the pathologic process of a ductus, it really is this path of blood shunting, right? A drop in our pulmonary vascular resistance ultimately leads to this systemic left to right shunting across that pulmonary vascular bed, which leads to that increased pulmonary blood flow. And again, due to the sensitivities of the capillary structure, we result in interstitial and pulmonary edema, and in severe cases, more prone to pulmonary hemorrhage. With all that blood flow that's now in the lungs are going to increase our increased preload. So we have enlarged volume load to that left side of the heart with an enlarged left atrium and left ventricle. The annulus, which is the annular ring that's on the left side, which houses the mitral valve, is a fixed structure. And so as this tissue, the LV, starts getting bigger and bigger and bigger as a sequela, oftentimes we can see mitral regurgitation as a sign of severe volume load as well, which as this annulus stretches, then that just further contributes to the next cardiac cycle, since if there's regurgitant blood going back into the LA, only comes back to the LV. And as you can see, then that can cause even further volume load. And then at the same time, the ductus does have this ductal steal, since there is no valve there, both during systole and diastole. So we have both a drop in systolic blood pressure as well as diastolic blood pressure. The systolic blood pressure is fairly maintained during systole due to the vasomotor properties of the vasculature, and the diastolic blood pressure is a little bit more exaggerated. So we end up seeing a widened pulse pressure there. And in severe cases, the metabolic acidosis, poor perfusion, shock, and mesenteric ischemia. And then that gets to all of those that I just mentioned. So these patients are typically risk for acute kidney injury, the splanchnic ischemia, we're at risk of necrotizing enterocolitis, and the fluctuations in our cerebral blood flow, we're at risk of IVH. So the supportive role, the ductus, we all know, provides a supportive role in congenital heart disease. And I like to think about it in three buckets. And so we'll talk a little bit about how each of these three buckets go. So the first bucket is our right-sided obstruction. So these are our ductal-dependent pulmonary circulation. The other side of things is our left-sided obstruction, so our ductal-dependent systemic circulation. And then lastly, we oftentimes use the ductus in a parallel or transposition circulation. So in right-sided obstruction, it's a typical lesions are your anatomic obstruction to pulmonary blood flow. So these would be tetralogy of Fallot with critical PS, tricuspid atresia, pulmonary atresia with intact ventricular septum, or we could see functional obstruction to the pulmonary blood flow in severe Epstein's anomaly, where the RV is so small or atrialized that it functionally can't eject blood out through the pulmonary valve. So the clinical presentation is typically cyanosis. The classic X-ray findings, and it's a board favorite, is you show these very darkened oligemic lung fields. And again, the patients can be hypoxemic, again, in the presence of having decreased pulmonary blood flow. So the ductus here is really required to add to that and to really provide the adequate pulmonary blood flow. So generally, it is left to right blood flow that you get from the aorta into the pulmonary artery out to the lungs to oxygenate. In fetal life, we classically see this because normally we're seeing right to left flow patterns. In severe pulmonary atresia or decreased pulmonary obstructions, or in the presence of pulmonary obstruction, we actually see a reversal of flow in fetal life. So we would see that left to right flow pattern. And then classically, we would see a reverse oriented ductus. So here's a picture of if you can see my mouse, this is the aorta, and this is the ductus. And what we look at is we look at the inferior angle of the aortic isthmus, or the descending aorta over here. And so this inferior angle of it, typically in a normal ductus orientation, is greater than 90 degrees. But in reverse orientation, you can see here is the aorta, and here is that ductus, making an acute angle here that typically is less than 90 degrees. And so in the presence of fetal life, where we see left to right shunting across the ductus, in addition to a acute angle that would be significantly concerning for a severe TET physiology or pulmonary atresia, or something that would be obstructing that pulmonary outflow tract. In left-sided obstruction, this is typically classically described as inadequate systemic blood flow. And so, your classic lesions here would be your hypoplastic left heart, your interrupted aortic arch, coarctation, critical aortic stenosis. And the clinical presentation here, usually, again, it's a sequela of decreased systemic or inadequate systemic systemic blood flow. So you would see patients with a clinical presentation of hypoperfusion, hypotension, oliguria, the metabolic acidosis, shock, decreased distal pulses, etc. In this case, again, that ductus is required here for adequate systemic blood flow. And one thing to note is that, and is important here, is that the first vessels that come out of the aorta, which are the coronaries, are oftentimes reverse filled by the aorta and supplied by that ductus. And so, again, looking and being cognizant in terms of our blood pressures, in this case, watching our coronary perfusion pressure here, which would be very much dependent on that patent ductus, ductal patency. Again, caveat in the most severe form that we see systemic outflow obstruction in our hypoplastic left heart. In this case, we don't have oftentimes any antegrade flow coming out from that systemic outflow. So in severe forms of mitral atresia or aortic atresia, all of that pulmonary venous blood flow comes into the left atrium. All of it gets shunted across that atrial septum. You have complete mixing at the right atrial level, down into the right ventricle, which then goes out to the pulmonary artery, and then you have the ductus, which then again is really a balance between supplying both the aorta systemic flow as well as that pulmonary flow. And so in this case, it's a balance between that QP and QS, and that's a whole other topic in terms of the pre and post management of these kids. So parallel circulation, this is a pretty classic, and boards love this question. So it's you have a patient that is cyanotic and comes in and is found to have either a transposition or a double outlet right ventricle with malposed great vessels. So both of those would typically provide a parallel circulation or a transposition physiology. With the DTGA and an intact ventricular septum, you're really dependent on mixing at that atrial level. And so classically, why do we start prostaglandins in these patients? The ductus provides that additional QP. And so in this case, as that PVR is dropping, which is very critical in the first 12 to 24 hours, otherwise we would see signs of a reverse differential cyanosis. But in this case, aggressively trying to get the PVR down and allowing that left to right shunting across that ductal level would allow for more pulmonary venous return, more left to right shunting of that oxygenated blood to that right side of the heart, and then ultimately out to the systemic outflow of that aorta. And so in this case, a restricted atrial septum, the ductus here is not adequate enough for that mixing because, again, it's the deoxygenated blood that's in the aorta that would go left to right back to the pulmonary arteries. And so in this case, what we would need is a balloon septostomy. Other ductal considerations for our congenital heart disease in a total anomalous pulmonary venous return or TAPVR. Typically, the ductus ductal patency here is controversial. Many leading experts here would say that there's a contraindication, especially if there's an obstruction to the cardinal vein, classically seen in infracardiac TAPVR. And again, with the ductal patency or being on prostaglandins, you could actually increase that pulmonary arterial blood flow and further make the respiratory distress as well as the lung fields with worsened pulmonary edema. Now, there are the reason for the controversy. There are some rare instances where the duct might be helpful. In the rare instance that you have a TAPVR with a restricted atrial septum. So in this case, you have a total anomalous pulmonary venous return back into the right atrium, either through a supracardiac TAPVR, an infracardiac, or a mixed picture. But unfortunately, you have a restricted atrial septum, so there's decreased flow from that right to left atrium. And in this case, you have complete mixing and you're fully dependent on that atrial level communication. In this case, you have decreased systemic flow due to that restricted atrial septum. And then in this case, that ductus is what's helpful for systemic outflow. In other instances, not so much for the ductus arteriosus, but starting prostaglandins in the rare instance of an infracardiac obstructed TAPVR at the level of the ductus venosus, sometimes PG is indicated. All right, so this is what we talked about at the very beginning, and although we see intersegmental arteries that most of them do go away, oftentimes there are instances in certain congenital heart disease where you have a persistent right-sided ductus, and so if you can follow the anatomy here, so you have this is your aorta, which would become the ascending aorta, the innominate into the common carotid and your right subclavian. And many times what would happen is that if you have a persistent right-sided ductus, this starts to atrophy. And so you end up this continuation of the right-sided ductus into the RPA, and you have this discontinuous RPA coming out of the first or second branch of the aorta. And so you can see in this diagram where the persistence of that right ductus leads to this discontinuous RPA coming out of the innominate or brachiocephalic trunk off of that first branch of the aorta. And this is a classic ductus or right-sided a persistence of the right-sided ductus with a discontinuous RPA. And so unfortunately, in some of these patients, we don't recognize it until the ductus has closed on both sides. And so in this case, we lose that RPA, and that's how they present. And unfortunately, at that point, there's not really much we can do. There's been some places that will try to retunnelize the right RPA to promote growth and try to rehabilitate that right lung. But generally speaking, if we can recognize this early, then we can do a unifocalization procedure early in life and reconnect that RPA back to the MPA trunk. Other ductal considerations, when we think about severe left ventricular dysfunction along with diastolic heart failure, So in this case, we're talking about a stiff heart with poor compliance and poor filling pressures or high filling pressures. In these instances, twofold, we could have decreased systolic function that is inadequate to actually pump systemic outflow. Or if we have diastolic dysfunction, oftentimes this leads to elevated LA pressures, which then creates backflow of your sort of a type 2 pulmonary hypertension, where you have secondary to LA hypertension. And then we use the ductus here as a pop-off for our right ventricle. And that gets to pulmonary hypertension. And so in this case, the role of the duct in pulmonary hypertension can be advantageous in a couple of ways. When we think about a normal heart with moderate pulmonary hypertension and severe pulmonary hypertension, in the second one, we have moderate pulmonary hypertension with elevated PA pressures, but we have continuation of RV to PA coupling. And so in this case, that open duct here, maybe bidirectional or right to left, helps reduce that RV afterload as a pop-off. And then in severe forms of pulmonary hypertension, narrowing of that duct in the presence of that severe pulmonary hypertension can lead to severe poor impaired RV perfusion. Now, how the duct can benefit or potentially be advantageous in pulmonary hypertension, there's three sort of mainstay potential benefits here. One, we just talked about, it provides this pop-off in severe RV failure, especially in situations where you have RV to PA uncoupling. And then the other two additional features would be in instances where you have severe RV dilation, we have interventricular or ventricular dependent dependency. And so how the RV reacts to the LV during systole, oftentimes it can push that LV such that you could have LV outflow tract obstruction. And in situations where you have LV outflow tract obstruction, the duct can then contribute to that systemic outflow. And then lastly, with the use of prostaglandins, in addition to maintaining ductal patency, it is also a vasodilator, and so it could also help with pulmonary artery smooth muscle vasodilation. So these would be the three potential benefits of using prostaglandin and maintaining ductal patency. Okay, so a little bit about prostaglandin. It's hard to talk about a PDA talk without talking about prostaglandins. A quick little bit of history. So in 1935, there was a substance in human semen that was originally altering the contractile activity of uterine strips. And so the thought was that this was coming from, in male reproductive organs. They called it prostaglandin as a hormone. And then in the 1950s, it really was the ability for biologists to classify what prostaglandin was, and it came from a prostanoic acid, which was a typical classical structure with several subgroups on it. And so those were all labeled A through I. And then with certain double bonds in that classic ring to denote a subscript 1 or 2. And so prostaglandin E1 or PGE1 was first isolated in 1957, and this was the first time prostaglandin was used as samples to be used for study. And then it wasn't until 1981 that the FDA finally approved PGE for the ductal patency in congenital heart disease. And so you could imagine prior to the 1980s, management of congenital heart disease was fairly challenging and limited. in many ways. And the opportunity for cardiac surgery and repair of congenital heart disease, even the field of congenital heart disease, really was changed once PGE was introduced. So for the boards, prostaglandin, it's a board favorite. They love to talk about the short-term effects as well as the long-term effects. Short-term effects, we typically see the apnea classically in the first 24 hours, although at low doses, 0.01 to 0.02, most studies will say that apnea is very rarely as a sequela. You could see the vasodilation of the peripheral skin presenting as flushing, hypotension, as well as fever. In the long-term effects, the classic one that everyone loves to ask about is the hyperostosis of the bones. And so this was actually a patient of mine who was on prostaglandins for about 2 months, and this was the one where you could see early on what the bone of this patient looked like, and then by the end of his use of prostaglandins, you could see that you started to see severe hyperostosis of the ribs as well as the long bones in his arms. And so again, the thought is that the prostaglandins, it is this hyperostosis. It is reversible generally, but oftentimes this can also present with bone pain and irritability. And so things to think about when we're on prolonged use of PGE. In a quick note about prostaglandins in CDH population, there's really limited data for the consideration of PGE use as an adjunct pulmonary vasodilator. There is some possible benefit in severe RV failure. Again, when we talked about the benefits in terms of using it as a pop-off or potential augmentation of cardiac output. In animal studies, it has shown to decrease as an inflammatory markers, including cytokines, IL-1 and IL-6 and TNF. And then again, there's been several single center case reports with some improvement of RV function with the use of PGE in our CDH patients. There was a large study in 2008 that did show that there was not a large benefit in human trials comparing INO versus INO and prostaglandin in CDH. So what are some of our definitive treatments for ductal patency? And so just a quick review, when we're thinking about how to maintain ductal patency, there's a couple of options. Classically, initially we talked about was the a type of a ductal patency would be a classic BT shunt or a Blalock-Taussig Thomas shunt. That became a modified version where there's a Gore-Tex conduit between the right pulmonary artery typically and the innominate vessel. Other types of shunts, which are more central shunts, but those can be the Waterston shunt or the Potts shunt, depending on the location of the pulmonary artery and the ascending and descending aorta. Again, the Norwood procedure does utilize ductal patency by providing that shunt with a modified BTT shunt. And newer procedures that are actually utilizing the duct itself through hybrid procedures of placing a stent in the PDA. For ductal closure, the definitive treatments are pretty straightforward. We either surgically ligate them or there are some novel catheter-based closures, which we'll talk about in just a little bit. And so these would be using occluders from a catheter-based manner to place a device that would essentially cinch the vessel together and prevent blood flow further. So, when we talk about definitive treatments for ductal closure and the PDA in general, it is a very, for neonatologists, it is a very controversial topic. And as you go through your training and as you see in your career, what we have found throughout its history is that it oftentimes tends to be a pendulum swinging from to treat or to not to treat. And the very first incidence was actually described by Mostyn Powell in a series for back in 1963. And this was a series of a case series of premature infants that had found a patent ductus arteriosus, and there was an association with respiratory disease. And so one of the first articles, again, that we think about from 1960s, and still even to this day, we find that there's controversy. And when we think about when to close, how to close, should we close, should we not close, you would think that a randomized control study would be helpful here, as well as to provide some equipoise amongst clinicians. What we found is that over time, since that study originally in 1978, which was the first randomized trial for the closure of symptomatic PDAs, where they actually just had a total of 25 patients in terms of medical management versus early surgical ligation. Since then, more than 80 randomized controlled trials have been in place. And unfortunately, even to this day, there is still controversy in terms of, or at least difficult consensus amongst clinicians whether and when to close the ductus. And for those that know Patrick McNamara and some of the hemodynamic specialists that throughout the country, what we've really found is that there are, as we start to look at the data, there are some reoccurring flaws found in our in these studies. And here are the top four, when we're comparing in terms of these meta-analysis, is that the patient selection is not relevant to contemporary neonatology. There is oftentimes inconsistent or invalidated definition of hemodynamic significance. When we look at those 80 plus randomized controlled trials, nearly 40% of them don't even use echocardiographic evidence to define hemodynamic significance. And then on top of that, those that do use echocardiograms oftentimes are using subjective markers or the use of the ductal size, which I'll talk a little bit about shortly. Lastly, many of these studies aren't truly randomized, where they end up being open label study designs. And lastly, much of these studies were based on intent to treat rather than having an outcome associated with the elimination of that duct. So, in terms of defining hemodynamic significance, this is the classic ductal size that many of these studies have looked at. But we all know that the ductus arteriosus is actually a complex three-dimensional structure with many different types and many different variations of what that structure looks like. And so, although in a two-dimensional plane, when we're doing echo images, that duct, if we look at it from on a hypothetical scenario, that duct that is 1.4 millimeters could actually be quite different in so many different variations of that. And we also know that, with these studies that do look at the diameter to decide on hemodynamic significance, when we look at the severity score on how it predicts the primary outcome of oftentimes BPD or death prior to discharge, the PDA diameter is the least reliable marker for its sensitivity. And so, again, when we're looking at the study design and when we're trying to compare these studies, I think it's difficult to ultimately draw conclusions and why it creates that controversy. So how do we define hemodynamic significance? And this is, again, where I don't want to be too prescriptive, but at the same time, I think it's helpful to provide a way of structure to have an idea of how to define hemodynamic significance, and know that every institution is different. But generally speaking, I like to think about it in three buckets. Bucket one, I think about as the characteristics of the duct itself. What is the size of the duct? Although that itself is unreliable, but comparatively, some studies have shown that, again, large ducts that are the size of the aortic diameter or the left pulmonary artery can have a correlation to hemodynamic significance. It's helpful to characterize the flow direction, whether or not we're seeing all left to right, right to left, bidirectional, as well as looking at Doppler profiles to see whether or not are we looking at a restrictive duct versus unrestrictive duct, meaning that as this duct is providing that flow, do we see a area where there's complete the pressure difference equalizes by the end of that Doppler profile versus do we see a fairly large gradient to show that this is a restrictive duct or a pressure restrictive duct. Bucket two here, I think about as the impact of the duct on the heart. And as we talked a little bit about the pathophysiologic or the pathophysiology of a patent duct, here what I would think about is really the RV health and how the duct affects the right ventricle in terms of its afterload, as well as evidence of pulmonary hypertension as evidence of RV hypertension. And then we know that because it's a volume load to the left side of the heart, to what degree of how that heart is accommodating in terms of the LV volume load, looking at the pulmonary arteries, the left atrium, the LV dilation, the presence of MR, et cetera. And then bucket three is really the impact of the duct on the body. And so in that case, I think about how the PDA is affecting in terms of the overcirculation or the pulmonary edema, as well as the sequela of a patent duct leading to diastolic steal, including the presence of mesenteric ischemia, oliguria, hypotension, and failure to thrive. And so, many groups have looked at it in different ways. Some have created scores to say, okay, you know what, if we look at all these three buckets and create a score guideline and try to help with how to help validate and decide hemodynamic significance. But what we found in a large population is that it is still quite variable and across institutions. For here at Children's Hospital of Orange County, we have two assessments. We have neonatologists here that perform targeted neonatal echoes, and so in addition to the clinical assessment that we do, looking at gestational age, respiratory, cardiovascular, GI, renal, and neuro, we also do a echocardiographic assessment, and so. Our first assessment is to see whether or not we are seeing all left to right shunting versus bidirectional at the level of the ductus. We also look at the ductal diameter, not an absolute number, but whether or not it's 2/3 the size of the LPA diameter. And then lastly, we'll see whether or not are we looking at a pulsatile duct defined as a peak systolic velocity twice that of the diastolic velocity. And so if we know all of those, then what we're looking at is essentially a unrestricted, large, all left to right with low evidence of pulmonary hypertension. And in that case, then we look at the hemodynamic points, which we give 0, 1, 2, or 3 points through a score. And I can go a little bit more into detail in terms of our scoring system. We look at our pulmonary vein Doppler here. So this would be looking at our S&D wave profiles, and based on the measurements, give it a score of 0 to 2. We also look at the flow going into the LV and looking at some of the diastology of the LV, looking at the mitral E wave. And whether or not it falls into certain profiles. We also look at the end diastolic volume of the LV itself using a parasternal short axis or apical 4-chamber. In this case, looking at the Z-score to see the volume size of the LV. And then lastly, we also calculate a measurement of cardiac output through the LV to see how much volume are we actually ejecting out of the left ventricle as well, and giving that as a point. And then our last one, which many studies have actually shown that this alone is a very ominous finding. But if we look at the aortic Doppler profile down in the descending and abdominal aorta, if there is absent or reversal of flow, makes a clinical concern for ductal steal and severity of hemodynamic significance, especially when you think about systemic compromise. This is just showing the angle of insonation that we use for our aortic Doppler profile. So trends for definitive closure of the ductus. In 2019, this was a nice study from Nationwide that looked at all of their interventions for their ductus closures. And as you can see across the country as well, that generally the amount of PDA surgical ligations have declined over the last 2 decades. With percutaneous closure increasing in many institutions. One of the largest pioneers of transcatheter ductal closure with the Piccolo device is over at Memphis at Le Bonheur. And again, had similar results where nearly all surgical PDA ligation has stopped since 2017, with almost all primarily preterm infants getting transcatheter PDA closures. So how is that affected in terms of the outcomes? We can talk a little bit about what devices and the safety efficacy of cardiac catheter closure. I'm sure many of you are familiar with this. For those that aren't, the Amplatzer Piccolo occluder is what we've now commonly used in our preterm infants. The FDA approved it for the use of preterm infants for greater than 700 grams and for greater than 3 days old. It is a self-expanding nitinol mesh device with variable sizes as well as a waist that is variable and is typically used for ductuses that are greater than 3 millimeters in length and generally at least less than 4 millimeters in diameter at its narrowest point. And it can typically be deployed on a 4 French catheter deployment system through the venous side. And so, the advantages of and disadvantages of transcatheter closures. Of course, intubation and general anesthesia is used both in the cath lab as well as in the surgical procedures. But the primary benefit here is that there's no thoracotomy. There's no need to cause lung collapse. There's been several reports now, all single-centered, that have shown low incidence of post-ligation syndrome, as well as the success of being able to occlude the ductus only by venous access. Again, the disadvantages, although there are a few places that are now doing it at the bedside, it does require a transport to the cath lab. It does involve radiation from fluoroscopy. As well as there is risk of injury in the heart, as well as some dislodgement and serious events, which I'll talk a little bit about in just a second. So, catheter versus surgical closure here. Again, some other benefits here is that it is a shorter recovery time, with some studies that have shown a lower respiratory severity score post therapy compared to surgical ligation. As well as less morbidity among survivors, specifically looking at IVH, sepsis, and the need for inotropic support postoperatively. And then because of the surgical procedure, there is risk of injury to the recurrent laryngeal nerve, which can lead to vocal cord paresis. Other comorbidities involving feeding issues as well as respiratory issues are also less in the catheter-based group. So the 3-year follow-up was presented now 2 years ago by Moore et al. And they looked at about 200 patients in 8 US sites that were using Piccolo. The implant success rate was about 95.5%, and followed up at 6 months with almost nearly all complete closure. Survival was 95%, and none of the 9 reported deaths were procedure related. The largest adverse effects here were aortic obstruction requiring a stent placement and tricuspid regurgitation, but none needing any intervention. So fairly, again, the safety profile in terms of its risk versus benefit use. There are some ongoing studies currently right now in terms of a randomized trial to really look at transcatheter versus conservative management. That's the pivotal trial where there's more than 20 plus sites that are randomizing early treatment versus conservative early transcatheter treatment in the first 30 days versus conservative management. And then again, some take homes now. The ductus has a heterogeneous role in congenital heart disease. I think specifically for pulmonary hypertension, ductal patency really should be thoughtfully carried out, especially in our CDH patients and who they actually benefit from. And then it'll be interesting to see what the next 5-10 years look like in terms of a paradigm shift as we become more comfortable with transcatheter closures in our hemodynamically significant PDAs. And that's all I have.
Thank you so much for a wonderful talk. Now it's time for any of the participants to either type a question in the chat if you don't want to speak, or you can unmute and we can go through any questions for Dr. Sen. And while that's happening, I also will put in an evaluation link in the chat box. Yeah, I have a hand raised. Yeah, go ahead.
Yeah, hi, Sean. This was awesome presentation. Great job with it. I guess I'm one of those old timers who's seen the pendulum swing from both ends. But my specific question for you is, on rounds, we always talk about what should we do with this PD on this baby. I was very fascinated to see that you're getting echoes in the first 72 hours in a less than 25 weeker, where I would expect that most of the ducts are still open. So what do you do with that information? Just out of curiosity. I know Iowa has started doing more early treatment. And there's a recent paper that showed severe BPD association if the PD is sitting on for longer time. So I guess my question is really, what do you do when it's open and 72 hours of life?
Yeah, Patrick's group are very aggressive in terms of at least identifying what the duct looks like. I think their first echo is usually in the first 24 hours of life on the preterm infants. We opted at 72 hours, again, more so for some of the neuroprotection that we do for our premature infants in the first 72 hours to just be cognizant about the golden hour, as well as to do just less is more. At 72 hours, when we first take a look at the duct, what we're really looking at is characterization of how the duct is appearing, as well as what are the initial influences with aortic reversal of flow. At 72 hours, most of our ducts, I would say, we're not really seeing the effects of left volume overload. But it does help us in terms of characterizing whether or not to start medical treatment. And so we will start medical closure if our FiO2 requirements are elevated, if we have significant respiratory distress, if we're still intubated without really any improvement in the first week. And generally, we'll start a pathway for medical management in the first week of life with either ibuprofen or Tylenol. Our first line treatment is ibuprofen. However, if there's contraindication either through GI reasons or the use of steroids, or with the history of low platelets, then we'll opt to use traditionally oral Tylenol, but also IV Tylenol. But most of our kids would get at least one medical treatment if we deem a duct is significant from that perspective. And then we try to identify those that are persistently either failed medical therapy. We leave it a little open to our colleagues in terms of how many courses of treatment we would give. Generally 2 at least, before then bringing it to our cardiology colleagues to do a transductal closure. But I think to your question, I think it's helpful at least to have a baseline imaging, or at least hemodynamic assessment to know where you are at 72 hours. And then again, I think there is literature now to suggest that aggressive, at least closure earlier on, might be beneficial in terms of reducing some of that BPD and death outcomes, at least for a certain population.
Yeah. And I think that's kind of where our group struggles. I wish we could be, like you said, very controversial topic. It's very controversial in our own unit.
Brooke, I when I was first asked about this, I thought long and hard how to do this delicately.
You've done a great job. Like, I really do want to say you've done an excellent job. And I guess our big question is always, that PDA you find on the kid that's on CPAP.
Yeah.
And sending that kid to be intubated in the cath lab, and what is that threshold for that? And are you really just looking at kids that are on mechanical ventilation?
No, we are looking at infants that are still stuck on CPAP or NIPPV, generally with an FiO2 requirement that has shown evidence of a hemodynamically significant PDA. We use our PDA score. If you saw the 0 through 3 points that they can get, if they score anything above 6, we essentially will follow the pathway and recommend closure or medical treatment. And so if they failed medical treatment and they still score a 6 or above, we then refer to catheter closure. The validity of ours, it's adopted by Afif El-Kufash's original score that was published, I think, in 2015 or 2016, but we modified it a little bit on our end, more for consensus amongst our clinicians.
There was just one question in the chat about the minimum weight for cath closure at your institution.
Yeah, that's a great question. So the FDA is approved for 700 grams. We have definitely teetered on that border and have looked as small as that. I would say the average is about 800 to 1,000. I don't know the number at the top of my head, but we generally close them fairly at a young age or a young size.
Any other questions or comments? Okay.
All right, thank you, everyone. Just to let everyone know what is upcoming is in March, we will have Brittany Schwartz talking about Beyond the NICU, Understanding Neurodevelopmental Risk and Outcomes for Premature Infants. So that will be March 19th. Sean, thank you so much for coming today. Sorry about all of the confusion.
No, not at all. I apologize. That was my fault. So
And
thank you so
thank you,
much.
everyone, for coming today.